Good morning, everyone. Happy to be with you and just show you a few slides about the right ventricle in ARDS. I do not have any conflict of interest. Just to remind you that pressure overload is probably one of the main causes of RV failure in the intensive care unit, and especially because of positive pressure ventilation, acute respiratory distress syndrome, but also sepsis and so on. But if you look at patients with RV failure, usually in the ICU, especially when they are under positive pressure ventilation, this is in relation with the pressure overload of the right ventricle. And in ARDS, there are many factors that may explain the pulmonary hypertension and as a consequence, the RV failure. You can see here that you may have a collapse of the pulmonary capillaries, especially due to the respiratory strategy. I mean, if you over-distend the alveoli, you will crush and collapse the pulmonary capillaries. But you can visualize that you have also other factors inducing pulmonary arterial vasoconstriction, as hypoxemia, hypercapnia. And finally, you have also some inflammatory factors leading to intravascular occlusion. So it's not pulmonary embolism, this is just microthrombi in the periphery of the pulmonary circulation. So for all these reasons, you have an increase in the pulmonary vascular resistance. If you look at the effect of mechanical ventilation, you have to keep in mind this slide, just combining what was described many years ago by Wittenberger, the relationship between the pulmonary vascular resistance and the distending pressure of the lung here, which is the transpulmonary pressure. Probably you know the plateau pressure minus the intrathoracic pressure. With the results and the studies of West many years ago, once again, about the different zone, just reflecting the interaction between the distending pressure of the alveoli and the flow into the pulmonary capillaries. And that's very easy to look at different zones in this relationship, which is not linear but curvilinear. And especially when the transpulmonary pressure is not so high, you see that even if you increase a little bit during TADI ventilation, this pressure, because you inflate some volume, there is no significant increase in the pulmonary vascular resistance because there is no generation of any collapse of the pulmonary capillaries. So no impact of the flow into the pulmonary circulation, which is not the case when you have a decreased lung compliance, or maybe if you inflate a too high TADI volume, because now you may partially or completely collapse the pulmonary capillaries. And so you observe the huge increase in the pulmonary vascular resistance. And so this is zone 2 or zone 1. This is something, the effect of pulmonary edema overpermeability pulmonary edema on the RV function, which was very nicely reported in this paper by the group of Brian Kavanagh. And they reproduced the study many years ago, which was to ventilate, for instance, animals with high plateau pressure, no PEEP, or it was exactly peak pressure, and the same peak pressure and the application of a PEEP of 10. And they well reported that indeed, when you apply high peak with no PEEP, they induced pulmonary edema and lung injury. And as a consequence, you have here the size of the RV. They were able to demonstrate in these animals an increase in RV size with this respiratory strategy leading to lung injury compared to the other one, which was more protective for the lung. Sorry. So how to suspect at the bedside RV failure in ARDS patients? First of all, and I think this is really key to have this information in mind, you have to monitor invasively the blood pressure through a catheter into the radial artery or femoral artery. And so now you are able to look at any variation, any respiratory variation of the blood pressure, and especially the pulse pressure. And finally, you have two possibilities. The first one, there is absolutely no pulse pressure variation in your patient. And so you have the information that there is no hemodynamic effect of mechanical ventilation on the RV. So no preload or no afterload effect. At the opposite, in some patients, you will look at some significant pulse pressure variation. It gives you the information that there is some hemodynamic effect of mechanical ventilation, a bad interaction between the respirator and the RV. But you do not know what is the reason why at this stage. And this is probably why you have to do an echocardiography in this situation, just to distinguish between the preload effect of mechanical ventilation. And so in this case, the RV will be non-dilated. You will have SVC respiratory variation as described yesterday, low CVP and a small IVC. And if the patient is in shock, you may discuss in this situation, according to the benefit-risk balance, the need for more fluids. But you have the other situation, which is that the pulse pressure variation is more related to RV overload. So this is an afterload effect of the mechanical ventilation. And so in this case, you will observe the dilated RV, eventually an acute pulmonale, no supravena cava respiratory variation, an elevated CVP, and a large IVC. And so here, as you know, there is no way for more fluids. You have more to think about adapting and optimizing your respiratory strategy, and maybe to do a prone position. Just look at this case, but I show you this case, but this is very typical, so this is why I show it again. So exactly, so we invasively monitored the blood pressure, and so we were able to this patient to just check that indeed at this stage there was significant pulse pressure variation. The delta PP was 28%. And so we decided to do a TEE. So this is a mid-esophagus view, of the TEE. And we observed a huge RV dilatation, right atrial dilatation, a completely compressed LV. So at this stage, because of the ARDS and the respiratory strategy, the patient had RV failure. What about the different risk factors for RV failure, or here in this study, acute cor pulmonale in patients with ARDS? This is a study that we did many years ago, just including retrospectively 752 ARDS, moderate to severe. You see that 22% of them actually developed acute cor pulmonale, and 67% of them had a shock. And what we found is that 4 factors were especially in relation with or associated with ACP. Pneumonia as a cause of ARDS, probably because of the inflammation into the lung. Driving pressure, which is the difference between the plateau and the PIP, at least higher than 18 centimeters of water. A PONF ratio below 150 millimeters of mercury, and a PCO2 at least higher than 48 millimeters of mercury. And so we decided to put 1 point for each of these items, and so to build a score, a risk score for developing ACP in ARDS. And you observe this kind of figure. with, for instance, if the patient had no risk factors or only one, the risk to have ACP was very low, below 10%. At the opposite, if they had 3 or 4 risk factors, the risk was very high, from 30 to 70%. So how to diagnose now when you suspect, how to diagnose RV failure? So by definition, and this is something that we discussed yesterday a little bit, probably that the echo is key to look at the size of the RV, but it could be a good idea also to combine this echo with a measurement of the right atrial pressure, or the CVP, because this may give you an idea about how the RV is stressed and how the RV is overloaded. And typically here, this is an echo with a TE with a very big RV, a small LV, and a paradoxical septal motion. So it was performed in a ventilated patient with ARDS, and this is a typical picture of what we call acute cor pulmonale. Why do we observe in this specific situation a paradoxical septal motion? Finally, that's very simple, and it was nicely reported here in animals many years ago. It's the invasive pressure into the right ventricle at baseline and into the left ventricle at baseline. And what the authors did, that they progressively induce some obstruction at the pulmonary annulus, so obstruction of the RV ejection. And you can see now along the obstruction that they were able to report an inverted pressure gradient between the RV and the LV. Now at end diastole, when the LV was relaxing, the pressure into the RV was higher than the pressure into the LV. And this is exactly why you may observe some paradoxical septal motion. It was also reported in humans, in patients ventilated for acute respiratory distress syndrome. It was done by my master François Jardin in the New England Journal of Medicine in 1981. It was a time where we were able to insert catheter into the right heart, very usual, but also into the left heart. And so you have here the pressure into the right heart and the pressure into the left heart with a PEEP of 12 centimeters of water. And you can see here, maybe there is some inverted pressure gradient, very small, at the end of systole. The pressure into the right ventricle is higher than the pressure into the left. But look at how, after applying in the same patient a PEEP of 20 centimeters of water, you can observe now a very large inverted pressure gradient between both ventricles. And this is exactly why now, using the echo, this is much less invasive, we are able to observe this kind of paradoxical septal motion, once again just reflecting this inversion of the pressure between both ventricles. If you look at the incidence in the literature of ACP in acute respiratory distress syndrome, you have these different studies. And so finally, this is between 25 to 50%. So you have just to keep in mind the number between 20 and 25. Just I want to comment this one, which reported 50% of cases of ACP, because it was, I will show you briefly at the end, it was very selected patients, very severe patients, in which we decided to do a prone position because the PNF ratio was still below 100 millimeters of mercury after 2 days of mechanical ventilation. How to support RV failure in ARDS? So this is a general slide, but that you may apply to ARDS. You have, of course, an hemodynamic strategy. As I told you, no way for more fluids, but maybe we may have, we will have some data in the future about the impact of removing fluids in this situation in the most severe patient. I will show you that norepinephrine infusion in case of shock is clearly the best approach. About the specific strategy for the ARDS, this is more prone position and some nitric oxide inhalation. And for the respiratory strategy, I will have not enough time, but this is clearly to limit the PEEP, to limit the plateau pressure, to correct the hypoxemia, to limit as much as possible the hypercapnia, and that's it. So just look at this evolution. So this is, let's say, the evolution along the time of this patient who developed a severe acute respiratory distress syndrome. After 2 days under mechanical ventilation, you can see that the driving pressure was 16, and that the plateau pressure was, I can't see on my slides because of the zoom, but was, I think, 23 centimeters of water. You can see no shock, no norepinephrine, and finally no paradoxical septal motion and a slight dilatation of the RV. Just look at, I want to show you this, sorry, a biphasic pattern, one peak and the second peak of ejection into the pulmonary, into the RV outflow tract, which is a good marker that there is some obstruction into the pulmonary circulation. And no problem with the mitral inflow. So the E wave was bigger than the A wave, so the LV was well filled and not compressed by the RV. After 5 days, the plateau pressure and the driving pressure increased more, and now the patient developed some shock, circulatory failure, requiring norepinephrine infusion. Look at now the right ventricle was a little bit more, was bigger. Some paradoxical septal motion now that you observe very nicely. You have this still biphasic pattern, but the VTI is probably lower. And after 9 days, the situation was very bad with a plateau pressure of 29 centimeters of water. We increased the dose, norepinephrine dose, and look at now the RV completely compressing the LV. You see here the increase in RV size during each tie-dye ventilation. In another view here, this is very obvious. So the obstruction induced by the pulmonary circulation, at least no ejection or a very small one, and the inverted pressure gradient, the inverted E and A wave, just reflecting that now the LV, the filling of the LV was significantly impaired by the RV dilated. So one word about the impact of nitric oxide inhalation in the RV function. We have some data in the past just showing that here this is in the normocapnic situation, and here in this hypercapnic situation. This is the pulmonary vascular resistance. And you can see that the nitric oxide inhalation, 2 ppm, so small dose, was able to decrease the mean pulmonary artery pressure here, but also the pulmonary vascular resistance. But it was especially observed in the situation where patients were hypercapnic, because probably in this situation, the basal, the baseline pulmonary vascular resistance and mean pulmonary artery pressure was much higher, so much better decreased by nitric oxide inhalation. That I show you the effect in a patient with ARDS. So this is the big video before a nitric oxide, and the small one superimposed is during nitric oxide inhalation. So look at the size of the RV here and here. Here the patient a paradoxical septal motion, a better, less paradoxical septal motion, at least no ejection, much better ejection. A pattern foramen ovale across, this is the red flow, no more during nitric oxide. So one more, so here the patient was in shock with high dose of epinephrine and norepinephrine, and here we were able, with nitric oxide inhalation, 10 ppm or 12 ppm, to decrease the dose of epinephrine and norepinephrine, and because the echo show you that the situation, the hemodynamic situation was much better. What about the norepinephrine? As I told you, only if the patient is in shock. Here, this patient with acute respiratory distress syndrome, paradoxical septal motion, and RV dilatation, the blood pressure was low, 80 millimeters of mercury for the systolic arterial pressure, and the base deficit was high, so metabolic acidosis. Look at after restoring the blood pressure with small dose of norepinephrine, we were able to correct the RV function, no more paradoxical septal motion, and no more, RV dilatation. And we were able, as a consequence, to correct the metabolic acidosis. One few words about the impact of blood gases on the pulmonary circulation and, as a consequence, the RV function. And especially, I told you that the hypoxemia and hypercapnia were able to induce a vasoconstriction of the pulmonary circulation. Here, this is very well shown in animals. This is the FiO2, just to induce in these animals hypoxemia. And here, this is the change in the pulmonary arterial pressure. You have here, during the open cycle, this is hypoxemia without hypercapnia. And so you see that the hypoxemia was able to induce a slight increase in the pulmonary arterial pressure. But it was much more magnified when the animals were in hypercapnia. The hypercapnia by itself was able to increase the pulmonary arterial pressure and to magnify the effect of the hypoxemia on the pulmonary circulation. So the association of hypoxemia and hypercapnia is a very bad association for the pulmonary circulation. Look at, for instance, here, this patient, it's not an ARDS, this is an acute exacerbation of the COPD. The systolic pulmonary arterial pressure was 80 millimeters of mercury when the pH at the admission was 7, so very, very low pH because of very high PaCO2. And look at after non-invasive ventilation and the partial correction of the pH, you visualize using the tricuspid regurgitation and the maximal velocity of this flow, normalization or a decrease of the systolic pulmonary arterial pressure, 48 millimeters of mercury. I show you now in ARDS, this patient, no hypercapnia, no paradoxical septal motion. And after the application of hypercapnia that we did just by increasing the PEEP and not to increase too much the plateau pressure, we were able to decrease the TADI volume. And so as a consequence, the patient became hypercapnic, and you observe the completely different picture now with a dilated RV and the paradoxical septal motion. And this is why maybe, but I just show you this slide, in the future, the CO2 removal using extracorporeal circuit could be interesting. This is just a study performed in animals, and you have a baseline with the PaO2 and the PCO2, the RDS situation when they applied the CO2 removal and when they stopped the CO2 removal. So you observe that the ability of the CO2 removal by definition to correct the hypercapnia induced when they did the acute respiratory distress syndrome. And what was interesting here, this is, I do not have time to discuss too much, but this is just a parameter reflecting the coupling between the RV and the pulmonary circulation. So the ability of the RV to well eject blood into the pulmonary circulation. And you observe that when they induced the RDS, this coupling was very well impaired and completely corrected when they were able to remove the CO2. And it was also the case about the pulmonary arterial pressure, increased during ARDS, normalized when they apply the CO2 removal. So just to show you the impact of the hypercapnia on the pulmonary circulation and the RV function, and probably in the future, the interest of doing some CO2 removal. What about the prone position? Very quickly, just to show you that because prone position is able to decrease the plateau pressure, to improve the oxygenation, to decrease the PaCO2 because you recruit the lung, the prone position is a perfect maneuver, a perfect strategy to prevent or even to treat an acute cœur pulmonale. And this is something that we reported in chest in 2007 in 42 patients. Half of them, as I told you, had an acute cœur pulmonale. And I show you here in this patient, 21 patients, that after 18 hours of prone position, we were able to observe a normalization of the RV size and not a complete normalization of the paradoxical septal motion, but a significant improvement. And you have here before prone position, this is the short axis view of the left ventricle with the paradoxical septal motion. And after 18 hours of prone position, you observe a normalization of the movement of the interventricular septum. I just show you to conclude a few slides very, very quickly about the RV in SARS-CoV-2 because we have some data. Just to show you this paper by Philippe Vignon showing that the incidence of ACP in a very small series, so it remains to be confirmed compared to ARDS related to flu, less ACP in these SARS-CoV-2 patients. Just to show you our experience in close to 80 patients admitted in our ICU, in whom we did a lot of critical care echocardiography, half from a transthoracic approach and half from a TE approach. Just to show you here the distribution of the cardiac impairment that we observed. So you observed 28% of patients who developed acute cœur pulmonale. And what is especially interesting here, this is the acceleration time of the RV ejection flow. You know that when this flow is decreased, this time is decreased, sorry, this is a good reflection of some pulmonary hypertension. And you may observe that in all the situations, and especially in the overall population, this time was very short, much lower than 100 milliseconds. And I just show you one example here. So the RV was dilated. You observe the paradoxical septal motion. And in this situation, it was related to pulmonary embolism, which is now a well-known complication in these COVID-19 patients. You observed here the thrombus, the clot into the right pulmonary artery, something that you are able to visualize if you perform TEE. And you have the same here. This is not in the right, but this is just at the bifurcation of the lobar arteries. Sometime we had also this one. The RV was dilated, a paradoxical septal motion. And now we visualize the clot just on the central venous line into the right atrium. So this patient probably developed acute cœur pulmonale, and not because of the ARDS, which could be, by definition, a risk factor, but probably because also of the complication due to clot into the right heart and into the pulmonary circulation. And I thank you very much for your attention.
Perfect. So just a couple of minutes before time, Prof. Antoine. So we have a couple of minutes for questions. Most of questions. Okay. How to overcome permissive hypercapnia to treat hypoxic patient in ARDS? That's a bit wobbly question.
I think the key point of my lecture is just to understand that first, hypercapnia has not to be a goal by definition. It's not protective. This is
only we missed your video. Sorry for interruption, Prof. Antoine. We missed your video. Is that on
Yes, but
purpose?
because I
Okay,
don't know,
that's fine.
I cannot activate anymore my video because
That's
the
fine.
system
Okay.
told me that you stopped the ability for me to
Oh,
activate
I'm
my
sorry for
video.
that. I'm sorry for that.
Okay, so no, so first, hypercapnia has not to be a goal by itself. So because this is deleterious, and the only effect of hypercapnia is just that you protect the patient because you do not induce too much volume, and you do not promote too high plateau pressure, for instance. So this is the way the hypercapnia may be beneficial. But on the other side, as I show you, hypercapnia may also induce, this is the price to pay, vasoconstriction of the pulmonary circulation and pulmonary hypertension with RV failure. And sometimes you are in between. You cannot give too much volume to correct the hypercapnia because it's not good for the patient. But because of the hypercapnia, you have RV failure. So this is some vicious cycle, sorry. So you are in a bad situation, and especially the patient. And this is probably in this situation that prone position is good because you may be able to achieve all the goals in the same time. So you decrease the PCO2 without increasing the TADI volume, and you decrease the pulmonary hypertension, and you improve the RV function. So just the message is that hypercapnia has not to be a goal by itself and may be deleterious for the pulmonary circulation.
Okay, and
allow me, because we are behind the time by 1 minute.
yeah, if you just give me 1 minute, Dr. Ashraf, if you arrange the medications of RV function treatment in the term of the best to the worst, epinephrine, milrinone, and dobutamine, what do you think?
We do not have many studies about the inodilators, which is milrinone or levosimendan, which could be interesting from a physiological point of view because they are expected to improve the coupling between the RV and the pulmonary circulation. They induce increased contraction of the RV, and they vasodilate the pulmonary circulation. So it's a good compromise. But we do not have so many studies. I have only one about levosimendan in my mind, which was published by Andrea Morelli in ARDS patient, just showing that indeed we improve the coupling, we improve the RV function, but as you know, the half-time of this medication is quite long and could be a problem, especially in patients in shock. So I will not recommend to infuse this kind of drugs. We need more studies. And probably, as I show you, either dobutamine, but I definitively prefer norepinephrine in case of hypertension to improve RV function.
Perfect. Thanks very much. And the mic to you, Dr. Ashraf.
Thank you. Thank you very much, Antoine.
Thank you.
Very nice presentation as usual. And probably the main message that Dr. Antoine wanted to deliver to all of us is when we deal with ARDS patients, we should not forget to look at the RV because
of course
RV is very, very essential for life.
Yes. Yes.
If you forget